right, hi everyone, you've made it. Last verbal session of the conference. This session is Eastern and Southern African WaSH. Unfortunately, our first presenter is not here, so we're going to be off by one. So we're going to start with Samantha Levalley from University of Toronto. Enjoy.
So, hi everybody. My name is Samantha Levalley. I'm a PhD student at the University of Toronto, and I'm here today to talk to you about the timing and volume of water collection at hand pumps and piped water systems in 3 rural communities in Zambia. This is collaborative work between the University of Toronto and the University of Zambia, and then we're funded by World Vision. So, as many of you I'm probably sure are aware, piped water systems are proliferating in areas where hand pumps were once the norm. So this is exciting, but there are some findings recently. So like the JMP in their 2023 report found that piped water systems were actually less likely to have water available when needed compared to non-piped systems like hand pumps. And we know that pipes can be beneficial. There's plenty of research to date to show the benefits of implementing this type of infrastructure. But we know that they also have functionality challenges. They often run with intermittent supply, and they're built with a mixture of private and shared taps. And so all of these things, their shortcomings can jeopardize that ability to provide sufficient water for user needs. So for this reason, these pipe systems are often built along other infrastructure like hand pumps, and users will commonly source stack. And so this image on the right is a convenient representation of what that might look like. So this is where a pipe system was built, and then you have a hand pump that was right nearby. And so to date, little is actually known about the day-to-day or hour-by-hour realities of how users might withdraw water from these co-located infrastructures. So for our research, the research I want to talk to you about today, we look at just this. So we did this by collecting hourly volume measurements from 3 pipe systems across 3 rural communities in Zambia. We did this by installing 104 water meters. And then alongside this, Charity Water kindly donated 8 hand pump sensors. These retrofit into the India Mark II. They donated these sensors to us so we could install those on just a few hand pumps in each community. And so these were installed back in May and June 2024, and they've been collecting data until, actually this weekend will be the last weekend that we'll have data for. And then yeah, we just have images of this on the right as well. So before I get into any of our results, I wanted to explain piped water systems can look very different depending on where you are. So the ones that we studied are solar-powered, gravity-fed systems. So these had a groundwater well that was solar-powered and pumped up to at least 1 or 2 elevated storage tanks, and then water flowed to 30 or 40 taps depending on what community we were in. Really wanted to emphasize that these piped water systems only served a fraction of each community. And so this is just a simple representation to show you what that might look like. So on one side, you might have a piped water system flowing to half the community, whereas the other half might just have hand pumps. And then you also might see hand pumps within the piped water system. I also included the sensor labels just to really, again, emphasize that we didn't have enough hand pump sensors to measure every single one in the community, but we have a few that we can look at today. And then lastly, some information about these communities. So they ranged in size, the smallest being about 78 households, the largest was about 270. We also did household surveys alongside the sensor data collection. We typically aimed for surveying the entire community, but we ended up finding anywhere between 86 to 93% of households. From this, we were able to collect a lot of information, but just for today, we can find out, we looked at like what primary water source people typically used. So I really wanted to just point out this row here. So for the pipe tap, even though these communities are very different sizes, they actually, a very similar population of people use the piped water system. It was something within like 20 to 30 people. And so, yeah, even though these communities are different sizes, the piped water system supplied a similar population of individuals. And so what were the realities of the water withdrawals from piped and hand pumped water supplies? So I first want to focus on, I'm going to focus on 2 major types of findings, volume and timings. So first we can look at volume. And so for this plot today that I want to show you, this is for the piped water systems first. We have average volume supplied, and this is a per person per day estimate. This was an estimation based on, like we had the total volume supplied by a system on any given day, and and then we divided by that estimated population that we collected in the surveys. So we have this starting all the way from July 2024 to July 2025. And this is what we see. So I have 3 different communities plotted in 3 different colors. I have every day on lighter points in the background of this plot, but then on the more solid dark line, this is a 7-day rolling average. And so I overlaid this with a 50 liter per capita per day standard because this is often something that we use, right, when we're designing infrastructure. So World Vision uses this to set the standard for what they want their systems to supply. This is the WHO benchmark. The government of Zambia has adopted this as well. This is what we typically want our systems to design. And so across these 3 communities, these were all designed to supply a similar LPCD per day. But we can see here that communities 1 and 2, at least at the beginning, generally, when you look at that 7-day rolling average, supplied over 50 liters per person per day. Obviously, community 3, even throughout the study, struggled to reach this. And then you see on any given day, this story could be different, right? We have really high average withdrawal days, we have really low days. So there's a lot of variation within this plot and even over time. And so some things I wanted to emphasize is that community 3 had the oldest piped water system of the 3 communities. And it was known to have operational challenges, like they had issues with their solar panels and pump, and it was known that it wouldn't be able to supply as much water as the other 2 communities. And then there are many potential reasons. I think I could spend a lot of time talking you through this plot and what these different trends that we're seeing, but there are a lot of different potential reasons that we're seeing these variations, ranging from seasonal water demand usage patterns to obviously cloud coverage because of their solar systems. To even operational choices, because ultimately, like, the thing that decides when people get water to their taps was someone walking to the system and opening a valve every day. And so it really relied on somebody going every day consistently to do that. We also did this for hand pumps, and so this is the same type of plot, but for our hand pump data. And again, we have average, this is the liter per capita per day, and then this is over time. We see a very different story emerge, and so from here we can see, and again, this is only 2 to 3 hand pumps per community, so it's just a subset. We can see that the volumes could be significantly higher in some cases, or again, below 50 liters per capita per day. And this is because the number of users often ranged. So in community 1, these hand pumps actually supplied less water overall compared to communities 2 and 3, so those orange and green lines. But there were many fewer users using them, and so that water then doesn't get divided as much. And then also we saw a drop in withdrawals at the start of the rainy season, so that would occur somewhere around October, November, and we see this sort of drop occur. That could be because of usage changes, like obviously rainwater becomes available, but we also theorize to some degree this has to do with drawdown in the wells as well. And then the other component I wanted to focus on for today is the timing. And so we saw I'm going to focus on just one key finding, but what we found was, so I'm going to show you across all of the days that we took this data. This is a cumulative distribution plot, and so I have every hour of the day shown here. So across the study period, we looked at, okay, on any given day, if we average out the water that's taken out, at what times do we see like 10% of the supply withdrawn for the day? At what times do we see 50%? When do people collect all the water that they have? And my animation did not work because this is PDF, but we see this plot on the left. And so, like I said, here we see, so between the hours of midnight to maybe 3 a.m., we can see that not much water is withdrawn. But then around 4, 5, 6, we see an increase in the volume that's withdrawn from these hand pumps. And then around 8 a.m., if we take that time in the morning, we see 56% of the total volume that would have come out of these hand pumps in a day is withdrawn. Then when we look at that same plot for the piped water systems, and we look at 8 a.m., we see that only 5% of that total water withdrawn from the pipes for the day was withdrawn. So this is really interesting because we see hand pumps, we know you have the freedom to go collect water whenever you want. And so we believe that this could be for any reason. Like, people go to collect water from the hand pumps in the morning because they want to. Maybe they go because it's less sunny. But then with piped water systems, because these are solar powered, because people wait until the sun comes out to start the pump, to pump water up to the tanks, we see that people are restricted in the hours that they can withdraw. So what do I want to leave you with today thinking about? I think implementers and regulators should really focus on the range of performance that we see in these systems. I think we often go to design standards like 50 liters per capita per day to set a standard for what we want our systems to supply. But when we use these averages, we can often mask the reality of these daily variations that we're seeing. And so one thing I recommend is when we're designing and building rural water infrastructure, we make sure that water is available at the times that people want it the most. And one way we can do this with pipe systems is making sure that we design and train our operators so that water can be left in tanks overnight so that it can be supplied in the early mornings. I think I'm low on time, so I'll skim through this, but there's plenty of more work that we can do with this. And I wanted to take a moment to thank our funder, World Vision, and if you have any questions that you can't ask me today, my contact information is here, as well as a paper we published a few months ago. Thank you.
Questions?
Is there,
Can you ask him the mic for the folks on that?
several questions. Is there a system of heating water day to day?
Sorry, could you repeat that?
Of heating
Of
water?
heating water.
Yes, for what? For bathing?
I believe so, but that's not something that we explicitly studied. I don't know. I actually don't know if people in these study communities heated water for bathing, but they definitely did for cooking and things like that. It's something I saw.
Just for cooking?
Yeah.
Seems to me it would be required. I say this because I was once related to a place when water was available. It was very, very low temperature. It was very cold, and everyone was very discouraged. So I just wonder that the same thing may not occur there as well.
Okay. Thank you.
Thanks, that's really, really interesting data to have and something to take away and consider. But in terms of the solar power and just having water availability, have you also looked at whether to also provide generator power to pump alongside the solar power pump as well?
Yeah, that's a really good question. So actually recently, generator, not so much, but in at least 2 of these communities, or maybe all 3, recently the ZESCO, like the national power company, they had been connecting some of these communities to the grid. And so a few of them, when they're expressing their frustrations with the solar, they're saying, like, I wonder if we could connect to the grid, if not for our main source, but at least for backup when the solar didn't work. So, yeah.
Great presentation, thank you so much. I've been interested in this question of like how much do pipe systems actually produce versus like what they theoretically are designed to produce.
Yeah.
I'm wondering about the per capita calculations. Was that just the size of the community, or were you guys able to count like the number of users or the number of people per household represented by those users?
Yeah, so for this presentation, for simplicity, we just used like basically like we had a total volume for pipe system, we had the total population, we knew based on the survey how many people use the pipe system, and then we applied just like a general total number based on pipe system usage. That wasn't the total community, that was pipe system, people who had reported using the pipe system. But in future iterations, we don't just have survey data for 1 period, we have it for 4, and so then I can even track like throughout the year and a half that we collected data, like did piped water system usage change, and then we can actually not only change it for time, but then like I even have people report the serial number that they use. So then we can look at, okay, like tap by tap, how equally is it actually distributed?
Very cool, thanks.
Yeah.
Hi, nice presentation, Samantha. I had, it's a question about a suggestion. For your time of day usage for the hand pumps, did you consider the fact that people might be turning up at the hand pump very early because there's a queuing problem? Could that be one of the factors, and they don't have to worry about getting there early when they're using the pipe system?
Yeah, that's a really good question. So I think in communities, definitely in community 2, so the one that had the lowest volume, demand was so high that I think queuing might be an issue, but it's in communities 1 and 3 not so much. But we did have, early on in our study, in one of those in community 2, like we had some structured observations as well, and we did see like there was quite a big queue around the hand pump, so that I think is definitely a factor as well. Yeah.
All right, let's give Samantha another hand. All right, and next we have Christine Marie George from Johns Hopkins University.
Thank you, Ryan. So my name is Christine Marie George, and I'm a professor at Johns Hopkins, and it's my pleasure today to present on our evaluation of the WaSHmobile, mHealth, and Chlorine E-Voucher program that we implemented in the Democratic Republic of the Congo. And this work is a collaboration between our research team at Johns Hopkins, Catholic University of Bukavu, the DRC Ministry of Health, and Engage Spark. And the rationale behind our work is that in humanitarian and other resource-constrained contexts, in-person visits for WaSH delivery can be logistically challenging, costly, and time-intensive. Furthermore, there's been mixed results in terms of reductions in diarrhea, of evaluations of large-scale community WaSH programs that had in-person visits. In this presentation, we'll provide evidence that mobile health messaging can be used as a light-touch, high-impact approach to facilitate WaSH behavior change. And so mobile health messaging presents a promising approach to facilitate WaSH behavior change given the high mobile phone coverage globally. And as you can see from this figure, in both low and middle income countries, phone coverage is high, so it's just showing 4G, 3G, and 2G coverage, and it's even high in both rural and urban contexts in many countries. And so this led us to develop our WaSHmobile program, which focuses on designing, implementing, and evaluating light-touch, high-impact WaSH mobile health interventions. And we focus on high-risk populations for diarrheal diseases. And one population we spend a lot of time focusing on is the household members of diarrhea patients. Because when a patient is admitted to the healthcare facility, their family members are at much higher risk of diarrheal diseases than the general population, with this risk being 100 times higher for cholera. However, despite this evidence, from both our site in DRC and other settings globally, the focus is almost exclusively on the care of the patient, and little attention is given to the household members who are at high risk of diarrheal diseases. And so this led us to develop the WaSHmobile program for diarrhea patient households. And this program was developed through formative research, which included semi-structured interviews, as well as pilot studies. And we ensured that we heavily engaged the community in the activities that we conducted. And so for the WaSHmobile program for diarrhea patient households, it's healthcare facility initiated. So a promoter delivers a Victoria WaSH module in a healthcare facility bedside to a diarrhea patient and their accompanying household members. We provide a hygiene kit, which we show in the middle here, which included a water vessel with lid and tap and chlorine tablets, as well as a hand washing station and soapy water, which is water, detergent powder, or water with small leftover pieces of bar soap. And then we reinforce the behavioral recommendations from the healthcare facility through mobile health messaging. And so these were voice and text messages that were coming from a doctor at a local hospital. And so here I show an example of a mobile health message. And again, these include both voice and text messages that we sent. And here we show an example of an interactive voice response message. And so the doctor from the local hospital is Dr. Pitcha, and she's calling a patient household shortly after discharge. These are all automated messages that are sent through the Engage Spark platform. And so in her call, she's asking the household to help her to explain to a patient how to correctly treat her water using chlorine tablets. And so households are asked to press 1 or 2 in response to a question on their phone, and then based on that, they receive a voice response with the correct answer. And so we conducted 2 large randomized control trials of this program, both in Bangladesh and in the Democratic Republic of the Congo. And so in Bangladesh, as you can see here, our trial was conducted in an urban setting in Dhaka, Bangladesh, of 2,626 participants that were randomized to be in one of 3 arms. Either the first arm was the standard message given on oral rehydration solution in Bangladesh, and then we had 2 WaSHmobile arms that were, the difference was one had no home visits, and then one had 2 home visits. And then we had a second randomized control trial in the eastern part of the Democratic Republic of the Congo in Bukavu, and this trial was of 2,334 participants. And we had a similar design. We randomized households to be in one of 2 arms. We had, again, a standard arm on oral rehydration solution and a basic 5-minute WaSH message. And then we had a second arm that had the WaSHmobile program plus quarterly home visits. And so we found in these 2 randomized control trials of nearly 5,000 participants that the WaSHmobile program significantly reduced healthcare facility visits for diarrhea prevalence over a 12-month period, as well as reducing the elusive stunting in children under 5 years of age at a 12-month follow-up. And this was both in Bangladesh as well as in the Democratic Republic of the Congo. And consistent with these findings, we saw sustained improvements in WaSH behaviors over a 12-month period. And both of these randomized control trials are published in Clinical Infectious Diseases. And so these findings show that in these 2 very distinct contexts, WaSHmobile was highly effective in terms of reducing diarrheal disease, as well as facilitating sustained WaSH behavior. And so our current work focuses on implementing approaches to be able to scale WaSHmobile to millions in the DRC, Bangladesh, and globally. And one thing that we realized when we started our work was that beyond diarrhea patient households, our recent study showed that those that are living within 500 meters of a diarrhea patient are at 12 times higher risk of getting diarrhea themselves that requires them going to a healthcare facility. And so by broadening the scope of the WaSHmobile program beyond diarrhea patient households, the intervention can serve millions more beneficiaries at high risk of diarrheal diseases. And so this led us to the development of the WaSHmobile mHealth and Chlorine E-Voucher program for these high-risk areas for diarrheal diseases. And so this program is initiated by an alert of a diarrhea outbreak in a health area, and this is in the Democratic Republic of the Congo. And so once there's an alert of a diarrhea outbreak, a health worker goes to the homes of these diarrhea patients and collects a GPS location. This is then used to send out voice and text messages to those that are residing within 500 meters of the diarrhea patient household. And they're sent from a doctor at a local health facility, and this includes both voice and text messages. The doctor is letting them know that there's a diarrhea outbreak in their health area, and that to protect themselves and their family, it's really important they wash their hands with soap and they treat their water with chlorine tablets. And they receive a text message that has a Chlorine E-Voucher number that they can then take to a local pharmacy or shop to redeem for chlorine tablets for free. And so to give some context here, I have an aerial shot of Bukavu, which again is in the eastern part of the DRC. And to give you a sense of what it looks like, this is a 500-meter ring in an urban context. And so you're looking at about 100 households in this 500-meter ring. And we partner with the local mobile network operators to send out both voice and text messages to those people within the 500-meter ring of the patient. And so they're receiving both a voice message from the doctor as well as this Chlorine E-Voucher. And so we conducted a pilot of this program among 2,022 participants, where we had both WaSHmobile areas as well as control areas. And we found that 57% of phone subscribers in diarrhea outbreak areas redeemed their Chlorine E-Vouchers for free chlorine tablets at their local pharmacies. And so this demonstrated the technological feasibility of this approach in terms of people receiving these E-Vouchers and then taking them to their pharmacy to redeem them. And so we conducted unannounced spot checks to see if people who redeemed their chlorine tablets, were they actually using them to treat their water. And so indeed we found that 64% of WaSHmobile households that redeemed their chlorine E-Vouchers had chlorine in their stored drinking water that was greater than 0.2 milligrams per liter, compared to only 20% in control households. Furthermore, we looked at safe water storage practices in these households, which were assessed through unannounced spot checks, where we observed to see if stored drinking water was completely covered. And again, this was significantly higher in WaSHmobile households compared to control households. Finally, we looked at hygiene practices, and this was assessed through, again, unannounced spot checks for the presence of soap in the cooking and the latrine areas. And we also found that this was significantly higher in WaSHmobile households that redeemed their E-Vouchers compared to control households. So in summary, these findings demonstrate that the WaSHmobile, mHealth, and Chlorine E-Voucher program was effective in terms of significantly increasing hygiene behaviors, water treatment behaviors, as well as safe water storage behaviors among this high-risk population. And in addition, through this pilot, we showed both the technological feasibility of incorporating this chlorine E-Voucher component, as well as the acceptability of this approach in the community. In addition, when looking at the findings from both our pilot as well as our earlier randomized control trials, it demonstrates that the WaSHmobile approach is highly effective in terms of increasing WaSH behaviors and has the potential to reduce diarrhea outbreaks in these high-risk settings. And so our current work focuses on engaging implementers, like many of you in the room, to incorporate WaSHmobile health messaging into your WaSH programming. And so this week we launched the WaSHmobile.org website, which we welcome you to come visit. And we have operational guidance on how to deliver this program in your context. We have example voice and text messages and other resources. And we also share the publications on the research findings that I presented today. I'll just give people a second. Thank you. And so with that, I would like to acknowledge our large study team that contributed to conducting this study, including my colleagues in the Democratic Republic of the Congo, at Catholic University Bukavu, including Jean-Claude Basimwa and President Servana, colleagues at Johns Hopkins, including Kelly Andreas, who's here today, as well as Elizabeth Thomas, as well as colleagues at the DRC Ministry of Health and Engage Spark, and then our funders, including Welcome, as well as the Rickett Global Hygiene Institute. And so with that, I conclude my presentation, and again, invite you to visit our website, WaSHmobile.org, and we're happy to speak to you more about incorporating WaSHmobile health messaging as part of your WaSH programming. Thank you.
Questions?
Thank you very much. Nice presentation. I wanted to know your audience and the content of your message. Are they all text or you also have voice?
So it's a combination between voice and text messages, and I can go back here. So we're focusing on those people who are residing in a 500-meter radius around a diarrhea patient. Let's see if they'll let me click back here. Uh-oh, it's not letting me click back. There we go. It has a mind of its own today. So when we have a diarrhea patient, we're going to those people who are within 500 meters of the diarrhea patient household, and we're delivering voice and text messages to them. The voice messages and text messages are from a doctor at a local hospital. The text message includes a chlorine E-Voucher. So it has a number, a unique number, that they can bring to a pharmacy or shop in their area where they can redeem chlorine tablets for free.
Thank you.
Mm-hmm.
Hi there. Nice presentation, very impressive results. I guess I have a question that's a bit similar, I think, to the other questioner. So with the voice messages, it means that you would be able to reach people who weren't literate and couldn't read SMS messages on their phone. But do you think that even though there's a very high rate of penetration of mobile users, that there are still households that don't have a mobile at all? And then would they be, I mean, how does that mess up your kind of, your results if the total population actually includes people who couldn't even receive a voice message?
So that's a great question. So we did mobile surveys to look at the coverage in the community. And we found around 86% of households reported mobile phone ownership, so it's fairly high. For that 14%, what we would normally recommend would be that they would go to their neighbor's house to get the information. But unfortunately, like I said, that we're not able to fully capture 100%, but we think 86% is fairly good. But that's a good question. And something else that we discussed, we're interested in collaborating with Tier Fund to scale this type of intervention, and we may need a combination between e-vouchers and paper vouchers in areas where mobile coverage is not high.
So maybe let me come in again. So in terms of scalability, so in Ghana we have something similar in my region, and our challenge was the fact that most of the people could not read and write. And even if you send the text, then it has to be in the local language. Yes, so that's why I was asking you of whether you were doing the voice. Because
Yeah, so we send voice and text. So we send both a voice and a text message, and even if they can't read, they know that what they've received in their phone is a Chlorine e-voucher. So they can take that to the pharmacy even if they can't see the SMS themselves, read the SMS themselves.
Okay. So, okay, all right.
Yeah, so we always send both voice and text messages because we found through our formative work that that was really important.
Any other questions?
Yeah, so happy, please visit our website and happy to answer additional questions you may have. Thank you.
Great, thank you. All right. And last but not least, we have Mindy Panulo from the University of Strathclyde.
Good afternoon, everyone. Apologies for my height. I hope it will do me justice. You'll be able to see me. My name is Mindy Panulo, and I'm a PhD student at the University of Strathclyde. And this afternoon, I'm going to take you through a presentation on willingness to pay, where we're trying to understand what are some of the monetary valuation of sanitation-related quality of life gains in rural Malawi. As much as we are able to acknowledge that over time, access to sanitation has improved, but still there are people who do not have access to basic and self managed sanitation. Most of the time, users of sanitation facilities, they value other things like safety and privacy on top of healthy outcomes. So these privacy and safety issues are examples of sanitation-related quality of life gains. However, these quality of life gains have never been included in economic analysis. Hence, it is important for us to understand how willing are people for them to value or to pay for something or to improve the sanitation facility to gain quality of life secondary to sanitation facilities. So one would ask to say, so how do we value or measure these quality of life gains? This is where now a new concept known as sanitation adjusted person per year comes in. It is, in short, it's called SAPI. So SAPI comes in to bring or to bridge the gap by putting a value on this quality of life gains. So how it works, the SAPI is it's a model that was adapted following the quality adjusted life year. So with the quality adjusted life year, where we are trying to understand the quality and the quantity of health over a year, with the SAPI tries to understand the quality and the duration of sanitation capabilities over here. So in our study, we use the SAPI as well as the SANCO tool. With the SANCO tool, it is a tool that tries to assess how people perceive the sanitation facilities by looking at issues like shame, disease, disgust, to say, how do you feel about your sanitation facility? Do you feel ashamed or do you feel disgusted with the sanitation facilities? So this, in our study, we combined the use of the SAPI as well as the SANCO 5 tool to understand these things. So as you can see on the far right, on the figure here, this is just an example of how the SAPI works. Just in summary, looking at path A here, path A is an example of a household that has an improved sanitation facility. Well, if time is going from 0 to 5, 10, 15, 20 years, you are able to see that the quality of life for that household is going down because of their access to an improved sanitation facility. On the other hand, when you look at path B, it's an example of a household that has improved sanitation facility. So the difference you are able to see here, the yellow shaded part, it's the difference related to quality of life. With path B, it is a household that their quality of life is constant over years because they have access to the improved sanitation facilities. While with the path B, the household, their quality of life is decreasing because of the unimproved sanitation facility. So in our study, we combined the SAPI as well as the SANCO, just trying to understand, to say how much are these improvements worthy to people in Malawi, so much that they are willing to pay for them to gain the quality of life benefits. So we conducted this study in southern region of Malawi in a district called Chiladzulu. Our study was conducted within 300 households, and we used a contingent valuation study to understand the willingness to pay. Just in summary, the contingent valuation study is a study that tries to understand the value that people put on non-market-based services. So we used the contingent valuation study, and it was more of quantitative in nature. Now, for us to come up with a figure that shows how much people are willing to pay for them to gain the sanitation adjusted person per year or the sanitation related quality of life, we went through several stages while collecting data. Firstly, we collected data about the demographics and also the sanitation data, which included, do these households have access to sanitation? If yes, what type of sanitation facility is it? Do they share with others or not? On top of that, we then had an activity whereby we did a double bonded dichotomous choice exercise. So with the double bond dichotomous choice exercise, we used maize in our context. Deliberately, we chose maize because maize is a staple food in Malawi. So during data collection, we introduced this exercise to the participants just to warm them up, so that when you're coming to the sanitation type of the DBDC, they are aware of how the exercise works. Additionally, the use of the maize DBDC in a study at this stage was also useful during analysis because it helped us to have precise value of the willingness to pay. Other than that, we went through a series of stages whereby we tried to understand how people perceive the current sanitation facility. At this stage, this is where we use the SANCO. We asked them to say, in the last 30 days, how often did you feel disgusted about your sanitation facility? So we did that, and after that, we then asked them to give us a scale of their sanitation facility using a visual analog scale. And then we then asked them, we had a vignette whereby it was describing a household that has an improved sanitation facility, and after time they upgraded the sanitation facility to improved sanitation facility, and then it explained how that brought quality of life changes in their life. And after that, we had an exercise whereby it was a hypothetical sanitation upgrade with the participants, just trying to give them a picture to say, if you are improving your sanitation facility, these are some of the things that can change related to your current sanitation quality of life. Then we finally did the sanitation DBDC like how we did with the maize. So here we're just asking them to say, are you willing to pay, for example, $17 for you to upgrade your sanitation facility? So how the DBDC works is you give them an initial amount. For example, you give them $17. If they say yes to that initial amount, automatically that amount goes up to say, what about if you're paying for $35? And after that, we'd say, okay, what's your maximum willingness to pay? Well, on the other hand, if they say no to the initial bid, the next bid will go down, and then we'll ask them to say, okay, you said $17, you cannot manage. What about $10? So we did that just to understand their willingness to pay. This is just to show you how it was in the field. So with the SunCode tool that I mentioned earlier, so this is an example of a household or a participant whereby they indicated to say, for the 30 days, I always feel disgusted with my sanitation facility, and also I always worry about safety regarding my sanitation facility. So after this, after going through the hypothetical sanitation upgrade, we changed their board to say, okay, hypothetically, if you improve your sanitation facility, we expect that instead of always feeling disgusted about your sanitation facility, now sometimes you may feel disgusted. That's the same even with the safety. So these are some of the changes we included. And then this is just an example of the visual analog scale that I earlier mentioned. For those people that were literate, they gave us the visual analog scale using numbers. For those that were not literate, they used the images. This is just an example of the hypothetical sanitation upgrade. For example, here, this is a household that is using a shared latrine, an improved latrine. So hypothetically, if they are to improve, we expect them to move from stage 1 to stage 2, whereby they'll have now a private sanitation facility, but still unimproved. And this is just an example of the DBDC I mentioned earlier, how the bids were working. One thing I should mention that was important in this is that when we're asking them about their willingness to pay, we ask them to say, hypothetically, we expect that you have this sanitation quality of life for 5 years. And also the quality of life gains, it won't be just for you, but also for the rest of the household members. And also just to be sure about their willingness to pay, we had questions that assess their certainty scale, just to make sure that the willingness to pay that we're getting is really what they mean. So this is just how we did the analysis. We take into account all the maximum willingness to pay for the sanitation facilities, their current and hypothetical visual analog scale, and also we did a regression analysis, and for us to have that stated amount, we used the estimate and then divided it by the household size average as well as the useful life, which was 5 years in our context. So from our study, we found that at least all the households were using sanitation facilities, although about 15% were sharing these sanitation facilities with others. And we noted that 94% of these households, they moved from an improved sanitation facility to improved sanitation facilities. So most of them were at level 2. Hypothetically, they moved from level 2 to level 3, whereby they're having still a private, but then at least with a concrete slab. And most of these latrines were built within 1 year because at this time they were being exposed to a COTS intervention. And on average, we found that the current sanitation facilities that these people were using, they spent at least $2.7 because one, they're using locally available materials, but also they built their facilities themselves. One important thing we noticed was that despite that people are using unimproved sanitation facilities, but their quality of life was relatively high. It was about 66%. The only things that were worrying some were about disease, disgust, and safety. But interestingly, although they were using an improved sanitation facility, they never worry about shame or privacy. And another thing regarding the maximum willingness to pay for sanitation facilities, we found that a good number of people gave us a modest amount of sanitation facilities, and about 10% of them stated a zero maximum willingness to pay. The reason would be one, because they said, I don't have money, so I can't pay anything, or else I'm not interested in improving my sanitation. So about 10% of sample size gave us a zero maximum willingness to pay. Coming to the most important part of this presentation is about the stated maximum willingness to pay for them to get the sanitation-related quality of life. So in our analysis, we had 3 groups of people. One, it was all participants. Those are all the 300 participants. And then we had some people who we thought or we considered them to say, before answering our questions, they carefully thought about it. And the third category, it was those people that showed that they were really sure they'll pay the maximum willing to pay. And this was our primary analysis. So our primary analysis was only the people that showed that they were really sure about their maximum willingness to pay. Important thing that we noted here is, when you look at these three categories, the maximum willingness to pay is changing. When you include everyone else in the study, the maximum willingness to pay is low, comparing to only when you use those that are sure about their willingness to pay. This is very important in economics, because sometimes when you're putting out a figure to say this is how much people are willing to pay, but if you include everyone else in the study, that doesn't give you a real picture. But in our study, we found this very interesting. And one thing we noted was that those that gave us a huge or a higher maximum willingness to pay to maize, it was associated with their willingness to pay for sanitation facilities. And interestingly, it didn't matter the gender of the participant. Both male and female valued the quality of life the same way. So in summary, this being a first study trying to put a value to quality of life gains, we have learned that sometimes people, although they're using and improved sanitation facilities, but they may feel comfortable with their sanitation facilities. That's why we found that relatively a good number of people had a higher SAN score at the initial stage. But we also noted that despite that Malawians, as already know, live in financial constraints, but at least they had a willingness to pay value to say, as much as I am constrained, but I have a willing for me to improve my sanitation facility. And another thing is just the issue of including sensitivity analysis to say, when we are coming up with figures, especially in economics, we don't have to include everyone, but we need to ensure that the stated amount of willingness to pay is coming from people that are really sure about their willingness to pay. So this is just a summary. I had a lot to say, but for further reading, you can have a look at our preprint, which is on Research Square. Lastly, I'd like to thank RGHI for the support through London School of Hygiene and all the collaborators from University of Strathclyde and Malawi University of Business and Public Sciences. Thank you.
Questions?
Congratulations on your excellent presentation.
Thank you.
Thank you so much. That was really interesting. And sorry if I missed it, I came in a bit late. But when you presented the last figures on the willingness to pay, did you make any comparison as to what that represented in terms of household income, or even if it was average household income in the area, and you have specific data related to that, to the individual? Was that comparison ever made?
All right, thank you so much. Yes, the comparison was made in a way that in a regression analysis, we included confounding factors like their willingness to pay for maize, which is a staple food, their household income, and also their gender. So during the analysis, that was controlled because we included to understand their level of income. So yes, it was included. Yeah.
I missed the...
I'm sorry.
Thanks. I think linked to that question around willingness to pay, was that looking at willingness to pay outright, or whether people would be prepared to take a loan to invest in their improving their sanitation?
Mm-hmm. Thank you so much. That's a good question. So when we were asking them, we were just asking to say, how are you willing to pay for the sanitation facility? That was just in general. But then during the certainty questions, we asked them to say, now considering that you have the money today, how sure are you that you're willing to pay? We didn't bring in the issue of subsidies or loan, but we just asked them to say, in case you have the money today, are you sure that you're willing to pay? So that one would say, I'm sure or very sure. And in our primary analysis, we excluded those people that said, I'm not sure I'll be willing to pay. We only included those that were sure or very sure, just to make sure that our stated willingness to pay is an exact amount. Yeah. Thank you.
And may I ask you about the distribution of the age of the patients? I didn't see carefully the distribution of ages. How do they go? How many old people? How many young people? Looking serious.
Thank you. So because this data was collected from a wider study, and our study participant was the household head, so the distribution ranged from about 25 to 68. Although I didn't include that, but it had that wide range of distribution.
So they were the youngest ones were 55.
No, 20.
25.
Yes.
60,
Yeah, thank you.
Household heads.
Yeah.
Thanks very much.
Other questions? Okay, thank you so much. All right, that wraps our session because we are one presenter short, so enjoy the early happy hour. See you next year.
Congratulations. Keep in touch with me with correspondence.
Thank you. Tomorrow.
My name is Nathan.
All right, yeah. Oh, good. Thank you.
In the United States. Very interesting.
Not too far to go.
No, we just get in our car and
You staying locally
yes, because an hour is short until you do
It's too much.
I'm sure several decades ago maybe, but not now.
Lovely to meet you. Congratulations.
Your presentation was just, because to plunge into that is not easy. No. We're coping with the same thing in starting pay to fetch for water. And we work in Ghana, Senegal, and Uganda. And in Ghana, during COVID, the government said to everybody, you don't have to pay for water during this time. And so that was a really long time. And then I come back and said, oh, starting now, everybody, there are no exclusions. So we have been really grappling with the willingness to pay, the ability to pay, and the differences. It's a struggle. So I loved your numbers.
Keep in touch, huh?
Yeah, I'll keep in touch. Thank you.
Thank you.
No rush right now, just letting you know the schedule was at 4:30 today. We will do